Good evening, ladies and gentlemen, my distinguished panelists, and all the viewers. I'm Dr. Nishant Sharma, and I welcome you to another virtual discussion. As we know, November is Lung Cancer Awareness Month, and this particular series is a joint initiative by Voice of Healthcare and Pfizer, where we talk about lung cancer and its awareness. So, without further ado, allow me to welcome my expert panelists. We have Dr. Abhishek Bansal, Medical Oncologist, SSB Hospital, ESI Medical College, Faridabad. Good evening, doctor. Thank you for joining us.
Thank you. Thank you.
We have Dr. Sujit Kumar, Consultant Medical Oncologist, Apollo Proton Cancer Center, Chennai. Good evening, Dr. Sujit. Thank you for joining.
Good evening.
And we'll be having Dr. Bharat Bhosale, Senior Consultant Medical Oncologist at Bombay Hospital, and Dr. Animesh Agarwal, Consultant Medical Oncologist, Apollomedics Hospital, Lucknow, joining us shortly. So to start this conversation, my first question to create and set the tone of this conversation, let's start with Dr. Abhishek. Dr. Abhishek, my first question will be for you.
Yeah.
So talking about lung cancer, what are some key factors contributing to the prevalence of lung cancer in India, and how does it differ from the global trends, as you know?
The key factors I will say, because of I will say first is environmental pollution and the air quality index, which goes on in India, and which give rise to the lung cancer cases here, and also the lack of awareness among the public for their health. And third is maybe screening guidelines are not implemented like the Western countries, and also limited access to health to healthcare practitioners. Mainly, people believe living in peripheries and villages believe in showing to RMPs or BMS doctors, and also the lung cancer is diagnosed as basically tuberculosis, and also diagnosed in late stages, which has low cure rates. And also the other specialties of medicine like homeopathy, Ayurveda are propping up. This also contributes to uh, misdiagnosis and delayed treatments.
Mhm. Right. Thank you, Dr. Abhishek. Good evening, Dr. Bharat. Thank you for joining us. I hope we are audible to you. Okay, we'll circle back to Dr. Bharat. Dr. Sujit, my next question will be for you. So while we talk about diagnostics, like Dr. Abhishek just mentioned about the delay in diagnostics, could you elaborate on the latest advancements in the diagnostic techniques for lung cancers that are available in India, please?
Great. So, as Dr. Abhishek mentioned, unfortunately, most of the patients who come to us are advanced stages, and that is because when the disease starts becoming symptomatic, you see, we need to understand the lung cancer symptoms are mostly either breathlessness or having blood in the sputum. These all symptoms start when the disease has really become big and it has started to affect the windpipes and fluids are there. So most of the time, I would say 8 out of 10 times when patient comes to us, we have them having an advanced disease. That is the lungs. It would have been the lungs. There would be water in the lungs, and it would have spread to the other part of the body. So first diagnosis always many times it's an X-ray which would have been done and followed by a CT scan from outside. And the two tests that are most important to diagnose and to stage the disease is one is a biopsy, and second thing is a whole body scan which we call as a PET scan. And for biopsy, there are two ways that most of the time the patients do go to the pulmonologist or the chest specialist, and the chest specialist do a bronchoscopy and take a biopsy from there. And in bronchoscopy also there are higher techniques, but first thing is bronchoscopy and biopsy. And suppose the lesion, the chest mass is somewhere in the side of the chest, then CT guided biopsy. So biopsy is very important. I have seen patients getting concerned whether biopsy will increase the disease, but I would like to use this forum to tell the people that biopsy is the golden standard of diagnosis, and biopsy always helps us to find out what type of cancer it is. And I'm sure we'll be discussing the treatment later, but the biopsy is the one which decides the treatment. So I would say biopsy for deciding what type of cancer, and PET scan for deciding what is the stage of the cancer. These are, I would say, the most important things that is needed for diagnostic purpose.
Right. Thank you. Thank you, Dr. Ji, for that answer. Dr. Bharat, I hope we are audible to you.
Uh,
Yes, yes, Dr. Bharat, we can hear you now.
yeah,
Hi, good evening, sir.
yeah. Good
So
evening. Good evening.
we're discussing with the rest of your co-panelists about what lung cancer is, what are some common diagnostics techniques that are used. My question to you will be, as we know, early diagnosis is important in any kind of treatment. So could you shed some light on the challenges that you feel are there in the early diagnosis of lung cancer in India, and how can these be addressed? Please, Dr. Bharat.
Yeah. So I think
Yeah. Dr. Bharat, you might be facing a little bad internet there. We aren't able to hear you.
am I audible?
It- you can maybe switch your camera off if you're having a low network. If you switch your camera off, it'll be all right. Yeah.
Yeah, yeah. There is some problem of internet. Sorry for that. I'll check out.
No
So
problem,
basically,
please.
see, yeah. So the basic problem with the lung cancer being an internal organ, unfortunately, not only in no developing countries, the same problem is faced by the developed nations. Majority of the cases are in advanced stage. Most of them are in the stage 3, and majority are no, sometimes they are stage 4 also. So as you said, what is the problem with early detection? It is in the lower and middle income country as well as in the developed nations. Now how to tackle this problem? You can either go to the high risk population who are smokers, but again the second problem is nowadays we are seeing this disease, particularly lung cancer, in non-smokers. So let's concentrate on our problem, Asian problem. Nowadays what is happening, it is developing in those patients who are non-smokers, and the basic
Hmm.
problem is second-hand smoking or environmental pollution, indoor and outdoor, both sides.
Right.
So rather than getting detected at early stage, it is better to have preventive measures,
Correct.
a strong prohibition of tobacco, so that the second-hand smoking should not be the problem for lung cancer development. Another problem is pollution. See, in Asia, the leading nation is China and followed by India. The indoor pollution in the form of in the rural India, we see a lot of lung cancer cases as well as in the the metros. So indoor
Hmm.
pollution is again a big problem because the air particulate size 2.5 micron is produced by a lot of chulas and kind of stuff used for yeah, the road women inside the house, and pollution, which is the another problem, which is the outdoor pollution. So I think we should concentrate on preventive measures. Yes, there are cases which we can pick up in early stages, and there is a trial. There are trials again from the Western worlds of low dose CT, try to detect the tumor at the early stages. But no, in our country we are going to have challenges. If you pick up those cases early, you need to have expertise available to pick up those first thing. Not every lung lesion which gets picked up should be biopsied. That needs to be discussed with a high volume radiologist, those who keep on seeing such CT scans. Again, biopsying in the inside the lung is not a simple thing. That procedure itself is associated with some kind of morbidity. Sometimes no patient lands up into ICU, and that has to be done by a particular radiologist, intervention radiologist, needs to be seen by an expert pathologist. Now, if everything is available, then I would suggest a screening for high volume, no high volume or mass at mass level. Otherwise, it is a precise thing. It has to be applied at patient to patient basis, not as a no for a big mass. That is a big
Hmm.
challenge to implement the screening test, which is called as a low dose HRCT. Again, you somebody can go and do a chest X-ray, but the trials are not very supporting a chest X-ray. So these are the challenges. So best thing is prevention. Prevention is the best thing. Still, holds true for
Mhm.
lung cancer.
Right. Thank you. Thank you, Dr. Bharat, for that. Good evening, Dr. Animesh. Thank you for joining.
Good evening. Thank you for asking me to be here. Glad to be here.
Yes, sir. If you can maybe switch your camera on. Yes,
Yeah.
hi. So my next question
Hi.
is for you. With the rest of your
Yeah.
panelists, co-panelists, we have already discussed about the different diagnostic techniques. Dr. Bharat was just talking about prevention, and my question to you will be coming over to the treatment. What are the primary treatment options that are available for lung cancer patients in India, and how does this compare to the international standards of care? Please.
Okay, so now that's a whole Pandora's box, you know. So I think I'm pretty sure these things have been already touched upon. But the number one question that you first need to answer is what stage the patient has been diagnosed at. So we use whatever symptoms the patient came to us with. We use whatever diagnostic modalities we have at our disposal, and we say we arrive at a diagnosis of lung cancer. So like now there are two types of information. First, we need to have one, what type of lung cancer we are dealing with. Now, lung cancer in itself is not a single diagnosis. It can be several different types of cancer, and that is both on what a pathologist sees under the microscope. So that is something what Bharat sir was also mentioning. Like we need expert pathologists who have worked in high volume centers, who are experienced at dealing with these things. So that morphological diagnosis, what they see under the microscope, that is a very very important part. And then today we now know that lung cancer is like God knows how many, like maybe 50 different types of cancers in one. So like depending on what has gone wrong at a fundamental level in the cell itself. So like most cancers are essentially our own DNA going haywire and producing a cancer cell. So what exactly happened? What was step one in this entire journey from one cell becoming a cancer? If we are able to identify that, then that also can define a lot of how we treat our patients. So, depending on the diagnostic modalities, depending on whatever tests we have, we arrive at a diagnosis and then we arrive at a stage. So, the modalities that we use for treatment are essentially three main things. We either use surgery, we can either use radiation therapy, or we can use what we broadly term as systemic therapy. So surgery and radiation therapy become what we can broadly call local therapy, as in जहाँ पर गांठ है, जहाँ पर cancer है, where the masses, we go and attack it right there. We either ask a surgeon to help us cut it out for the patient. If that is not possible or not practical, cannot be done, then radiation can be used. Radiation is nothing but high energy X-rays or CT scans. It uses the same X-rays that a regulation X-ray or CT uses, but they're very high energy beams, and they are used to essentially burn the cancer while the tumor it is still there inside the body without actually going in and touching it. So that is radiation. That is another modality that we can use. And then when we come to systemic therapy, then now that's a very broad term, and for that we can use chemotherapy. It could be targeted therapy depending on what molecular abnormalities we find, or it could be immunotherapy in the modern day, which is the current buzzword. But obviously not all patients are eligible for all forms of treatment. Some patients may be happy, maybe for some patients just a single modality may be sufficient, and some patients may require a combination or permutation of various modalities. That obviously would depend patient to patient given all the information that we collect.
Right. Thank you, Dr. Animesh, for that wonderful answer. Moving over to the next round of discussion where we talk about patient education, about advocacy. My next question will be for Dr. Abhishek. Dr. Abhishek, I hope I'm audible to you.
Yeah, sure.
Yes, sir. So my next question is, how can we build and advocate a multidisciplinary approach to enhance the outcome of lung cancer patients in India, and what do you feel are the key components of this approach?
I think first we should focus on the screening part. It should be strictly followed. The
The
screening
host,
guidelines should be strictly followed.
there is some problem,
And
technical problem with the host is not able to join.
hello.
Yes. I am able to hear you, sir. Please.
Okay. The screening guidelines which
So
are
those who are
practiced in the Western country should be
joined
followed.
in this awareness talk, the most
Uh, yeah, you can continue. Maybe I'll just put everyone on mute. Dr. Abhishek, please continue.
Yeah.
Dr. Animesh, can you hear me?
Who is speaking?
Yes, I can hear whoever it is that is speaking.
Dr. Sujit here.
Oh,
Yeah,
sir.
Dr.
Okay.
We can hear you.
Okay. Apollo, sir.
We can hear you.
Okay.
I think our Dr. Nishant is not.
Sujit, we can hear him. Dr. Sujit, we can hear him. We can hear you. We can see you. I think there is some problem.
Dr.
Yeah,
Sujit,
I'm
maybe
thinking Dr.
you can
Nishant
log.
Sharma's phone. I'm not able to
Yes.
hear Dr. Nishant. That's why I was asking.
Yeah. So,
Okay.
Dr. Nishant, we can hear you. We can see you. We can see Dr. Sujit. I can see Dr. Bansal. There is some problem with one connection, I guess. So, Dr. Abhishek Bansal is discussing about the advocacy part and patient advocacy part. So let's
Dr.
hear
Sujit,
him
if you're
out.
having some trouble, you can maybe log off and
Able to
re-log
hear
in.
Dr.
I think that
Abhishek.
is going to. Yeah.
So let's hear out Abhishek Bansal, and then Dr. Abhishek Bansal. After Abhishek Bansal, we'll go to Dr. Sujit, so we can check his connection.
Right. Dr. Abhishek, please.
Yeah. So I was talking that screening guidelines should be strictly followed, and like the guidelines in the West, like patients who are smokers for long term can be advised low dose CT scans above the age of 55 years, and people should be concerned about the harmful effects of smoking and usage of BD cigarettes, and including the role of their close partners. And we can use de-addiction. We can have the help of de-addiction centers, and their partners who are passive smokers. They can help them in leaving smoking, and usage of nicotine gums and nicotine patches. And primary healthcare practitioners who are practicing should be told about the common symptoms, and to diagnose lung cancer earlier, and not to misdiagnose them as tuberculosis, to keep treating them as uh, tuberculosis with AKT, and finally they are diagnosed in late stages. So they should be told about the common symptoms, and if AKT is not effective even after 1 month of patients with cough with hemopsis, so they should be think upon an alternative diagnosis. And I think early referral system should be practiced to an oncologist in on the slightest suspicion of lung cancer.
Right. Thank you, Dr. Bansal, for that answer. Dr. Bharat, my next question will be for you. Continuing about patient education and advocacy, how do you feel? How can patient education and support play a crucial role in the journey of a lung cancer patient? And what resources are available in India for this purpose? Please share.
See, advocacy group, and this is okay. I think apart from patient education, it is very important to go and educate the general practitioners, the family physicians in India. As no, Dr. Abhishek was mentioning, continuation of the AKT was going on. Now, our beyond the general practitioners, we have now been talking to pulmonologists to do proper tests to rule out tuberculosis, because tuberculosis is a major problem still in India, and that is why we miss out those cases in early stages where the lung patch is considered as tuberculosis and patient is taking tubercular drugs for long, and then the lung cancer goes from stage 1, and this happens in couple of cases. Fortunately, nowadays there are advanced tests to clearly mark out tuberculosis separately and lung cancer separately. So our pulmonologist colleagues are doing all those tests. Going to the community physician levels, whenever they do suspect, as he said rightly, if the something which is in the lung not responding to antibiotics or tubercular drugs, immediately you should raise the alarm and send the patient to a proper oncologist, be it a surgical oncologist, radiation, or a medical oncologist. So now this patient education involves that if you pick it up in early stages, yes, in some percentage of cases, it can be addressed with local therapies. As the Dr. Animesh has mentioned, there are local therapies, surgery, and radiation. Unfortunately, I was mentioning it is not beyond 15 to 20%. Even if you do all education and try to do screening, our percentage of picking up the disease in early stages is very poor. It is not beyond 15 to 20% with whatever best available resources. So 80% of the cases still are in the stage 3 advanced and metastatic stages. So people do need to understand that still in these cases, 50% of the cases, if we properly diagnose, see, do understand, properly diagnose means the patient goes to a proper doctor, oncologist, get the biopsy done, all staging workup done properly, and this tissue needs to be evaluated with a proper pathologist. It's not only oncologist. The radiologist has to do his job properly. The pathologist has to do his job properly. As Dr. Animesh was mentioning, there are 50 different types of lung cancer. That means if some lung cancer cases in a day, 50 lung cancer cases walks into my clinic, there is something called as a molecular analysis that divides the patient into different types of treatment. So the treatment is also precise, which is called as a precision oncology or personalized treatment. Not all the patients are going to be treated with the chemotherapy. See, there was a time when we used to do only FNAC. Few cells used to be collected and just diagnose that it is lung cancer, and all the patient used to be treated by chemotherapy. Patient has to understand this is a tedious process, but they have to be patient to do all these things. What happens nowadays, patient walks in our clinic, You advise some tests, they feel that no, it is going to take some time, but this is for the patient's benefits. So this idea, when you sit and counsel the patient, so these all steps are very, very critical. I can write a treatment in one day, but before me, the pathologist has to do their job properly. The tissue has to go to the lab in right vehicle, in right time, needs to be collected, should go to the molecular pathology. All these things will give a percentage of patients for tablet forms of therapy, which is called as oral targeted therapy. And those patients may or may not require chemotherapy. Those patients
Dr.
can
Bharat, your
be
connection is breaking. If you can
treated
switch your camera off,
with
we
oral
aren't
therapy
able
like
to.
a diabetic or hypertension pills. And the research has shown, or we know, yeah, I hope I am. So this is a very important part. So with the targeted therapy, now not only in clinical trial, but in reality, we all of us have patients to
Dr.
that
Bharat,
there
you
is
just
yeah, I'm trying my
you
best.
unfortunately just muted yourself. You can continue, please.
Okay, so can you hear me? Yeah.
Yes,
So
sir.
so with the targeted therapy, patients are living with the tablets. There are wonderful tablets, but the main thing is you have to diagnose these cases. Then there is something called as immunotherapy beyond the reach of masses. But now with the compassionate access and clinical trials, some of the patients are getting access to immunotherapy. I can say 20% of the patient gets excellent response, and some of them who maintain their response beyond 1 or 2 years, you we are able to label few of them as a cure, which was not possible a decade back. So targeted therapy and immunotherapy had changed. But the patient has to understand this is not for all patients. This is very expensive treatment. There are no groups, NGO groups, who come forward and support some of the treatment, which actually changes dramatically the outcome of the disease. Every time it's not like that. It is very expensive and beyond the reach. So for a disease where 5 year survival or a 5 year survival was not more than one digit, like 5% or 10%, I see more than 30 to 50% of the patients are surviving beyond 5 years. Those patients who do well beyond 5 years, I think again a 50% of that can go up to 50 years. The science is evolving. This kind of a amazing response was never seen in last 2-3 decades, and I feel that the future is bright. The patient has to understand after the diagnosis they have to take a just a little bit patience with what their doctor tells. These tests are very, very important. If there is a problem in doing all those tests, there are supportive groups in majority of the hospital. Fortunately, in metros, 2 tier 3 tier cities are evolving. And no, there are patient support groups where those patients who do survive, they form their group, they educate these patients, are existing in different metros. And I believe other cities also having these patient groups, and the NGOs.
Right.
And it is
Right. Dr. Bharat, your voice again cracked. We aren't able to hear you.
very important nowadays. Patient advocacy, like big conferences where the science is presented, the
Right. Dr. Bharat, you appear to be having a poor internet connection. Your voice is missing out in the middle. Yeah. Maybe we'll circle back to Dr. Bharat in the next round of discussion. My next question will be for Dr. Sujit. Dr. Sujit, I hope I am audible to you now. You're
Yeah.
on mute, sir. Yes.
Yes.
Okay. So while Dr. Bharat was just talking about the newer advancements, my next question will be building on the same. So please provide some insights on promising research and advancements in the lung cancer treatment that you feel is there in the Indian context. And also tell us about some aspects that you feel require a scope of improvement, please.
Yeah. So you see, as Dr. Animesh rightly pointed out, the different aspects of treatment. For lung cancer, the treatment includes surgical treatment, radiation therapy, and medical. We call it a systemic treatment because previously it was only chemotherapy. Now we have chemotherapy, targeted therapy, immunotherapy, etc. for lung cancer. Now, regarding surgical treatment, now one of the more important things that have happened is use of robotic surgeries, which have reduced the morbidity. The results may be the similar, that the surgical efficiency may be similar in the terms of the outcomes, but the morbidity is less. I am now finding my patients who get a lung surgery, within 10 days they are in front of me sitting for the further treatment, and that is very important because the hospital stay, the blood loss, and the yield of the surgery is much better using robotics or what we call as video assisted thoracoscopic surgery. So in surgical field, the use of robotic surgery and VAT surgery has improved the outcomes in terms of morbidity and post-operative recovery. Previously, when we used to do our MD and DM, we used to have large wounds which were not healing, and they used to have a lot of pain. So I have seen patients are much better after such minimally invasive surgery. So that is one advancement that has happened in surgical aspect. Regarding radiation, all of you know previously it was a cobalt era. Now we have linear accelerators, and even in linear accelerators there is something called as image guided radiotherapy, especially for lung tumors which are very much moving with breath. So it is important that we don't treat normal tissues, and we treat exactly the tumor that is there. And there are different mechanisms, and one of them is called image guided radiotherapy, where we are exactly precisely treating the tumors, and different mechanisms are there for that. And recently there is proton therapy, especially for small tumors which are having which I would say to reduce the dose to the normal tissue, especially if the patient has something like a bronchiectasis or something like a bad lung, then it may be useful, especially if they are not operable. So we have something known as medically inoperable, which means old patients 70 years plus, 80 years plus, they are having a small tumor, but they are not being able to get they are not being able to go for surgery because they have a cardiac condition or an uncontrolled hypertension or diabetes. So in that situations, when there is a small tumor which has to be treated but surgery is not possible, there is something known as stereotactic body radiotherapy or stereotactic radiosurgery, which is useful in such situations. So again, in radiation, the most important advancement is stereotactic body radiotherapy or stereotactic ablative radiotherapy, especially in patients who cannot undergo surgery. Again, the treatment gets over faster and the recovery is good. Coming to medical oncology, as Dr. Bharat rightly said, two things are very important nowadays. One is the molecular testing, which basically means that the DNA in the cancer cell has many what we call genes which are activating the cancer to grow very fast. So these genes, if we can know by doing genetic test or molecular test, we can use treatment directed against them, and that is known as targeted therapy. There are at least 12 targets which are targeted, and as Dr. Bharat said, we are able to see long-term cure or long-term disease control because of this targeted therapy. And that is most of the time they are oral medicines and very easy for the patients, not much of side effects. So chemotherapy is now just one of the treatment options. Targeted therapy has come in a big way, especially in non-smokers, in younger patients, in females. We are finding them to be positive. Now coming to immunotherapy, again immunotherapy is this last decade, or like I would say last 5 years, it has been about immunotherapy, but not like targeted therapy. Immunotherapy is not that what you saw. You cannot say that it was very efficient in that it doesn't take care of all the patients, but the patients who have response, the patients who have some markers which are positive, they have excellent response to immunotherapy. The best part of immunotherapy versus chemotherapy is that the side effects are very less. I would say less than 10% of the patients have major side effects, or even less than 5%. They tolerate it very well, and not like chemotherapy. And the response which happens with chemotherapy, many of the times they are short lived. And in case of immunotherapy, if we have response to immunotherapy, we see they respond much longer times, many years. So that is very important for lung cancer, especially advanced lung cancer. So to summarize, for surgical plan, the robotic surgery, the minimally invasive surgery is the advancement. In radiation, stereotactic radiotherapy or image guided radiotherapy is an advancement. And in case of medical oncology or systemic therapy, immunotherapy and targeted therapy are the advancement. After seeing all this, the most important one more aspect is the supportive care. Previously, if you give chemotherapy, patients used to have a lot of side effects, vomiting, admission, and low blood counts, infection. Now the supportive care has improved very much. So chemotherapy, even though it is the same chemotherapy, patients are able to tolerate it much very well. They are not getting admitted because of side effects. The treatment is less toxic and easily, even for a patient of 75 years, we are able to give them chemotherapy because of there are injections called WBC boosters, which we when we give, the blood counts do not fall and they are not prone to getting infections. So supportive care also has improved very well. So I think as a whole, even if it's an advanced lung cancer, the patient are able to treat and get better, and the treatment journey also is not very toxic like in previous times.
Right. Thank you, Dr. Sujit. One last part of the question was the scope of improvement. Any area where you feel that it requires some scope of improvement in the entire treatment horizon that you just spoke of, please.
Yes, you see, the many times we have situations as medical oncologists, I am sure Dr. Bharat and Dr. Animesh will all agree, the advancements that are which I have explained have not reached into the masses. It has not reached to the masses, or it has not reached to our people because of many reasons. And one of the main reason is the financial access, and immunotherapy especially. We I would say we have a study from Tata saying less than 2% of patients actually afford immunotherapy, and that is one thing, financial access. And that means we need to have much more support from the government schemes, which we need to have much more NGOs coming forward to support the patients, especially patients who are very young and who have targeted therapy options. I have a patient from Assam. He's 35-year-old. He has an ALK positive. Now when we started the treatment, we were not sure whether how will he afford. He was just working as a manager in a local company, but later, after he went to his place in Assam, he was fortunate to get a state government support from the State Cancer Institute, and he's getting his medicine, which normally costs 90,000 per month, for the last 3 years. He had an advanced stage; he's now fine, but for the last 3 years, he's getting it absolutely free. I understand it may not be possible for everyone, but we should have those targeted therapies which really good have good results. And when the patients are young, you see, they are breadwinners, they may have a small kids, such patients definitely may be a preferable choice. So financial access is one advancement. I would say whatever advancement we do in science, if it is not accessible to our people, that has no meaning. It is just a theoretical value for them. Second thing is, I would say the laboratory services have to be improved so that patients get faster molecular reports and the treatment can be started better. And third, I would say, is the you see, the treatment has to be always a multidisciplinary treatment. It is not that the surgeon gives chemotherapy or the radiation doctor gives immunotherapy. That is not the way. Everyone has expertise in their own field. So as medical oncologists, we always see, and all the studies say, when a patient is taken care in a comprehensive center with all the departments having a tumor board, so multidisciplinary tumor board based management is always in the best interest of the patient, rather than one doctor doing everything. That era is gone. It is actually every doctor who is an expert should be involved. So this is the third practical thing. The other things, I would say, even if we have good advancements in treatment in US or Europe, I'm not sure whether next 2 3 years we'll have it here in India. Although we can make it available, but all these issues, access, finances, and this thing that the patient may not be seen by the right person who should be doing the treatment. In case of systemic treatment, it is a medical oncologist. In case of radiation, it should be a radiation oncologist, and surgeons definitely is a surgical oncologist. So I think that is more practical way. The advancement should be in access, I would say that.
Right. Thank you, Dr. Sujit, for that wonderfully insightful answer. Dr. Animesh, my next question will be for you. Building on the conversation that Dr. Bharat and Dr. Sujit just mentioned about patient groups, please share some awareness initiatives that you're aware of that have made a significant impact on lung cancer outcomes in India, and also for individuals who want to get involved. What is the way, please? Uh, Dr. Animesh, we are not able to hear you. Uh, no. Can the rest of the panelists hear Dr. Animesh? Dr. Animesh, you're not audible, unfortunately.
Is it muted, Dr. Animesh?
No, he is not muted. Can you try now, Dr. Animesh, please? No, sir, you're not audible. You might have to just drop off and come back. We'll circle back to you with the same question. Right. Meanwhile, Dr. Bharat, my next question will be for you. How has COVID-19 pandemic affected lung cancer care? And as a clinician, as a medical oncologist, what are some precautions that you feel patients should take for the same, please?
So, regarding this question, regarding COVID-19 as well as subsequent things, my answer to this question is my personalized, answer. Don't make it a generalized statement. I have my own views because I see patients after COVID. I used to see lung cancer 10 years before COVID. So, what I have observed is like, no, we have a lot of information coming up. People have no improved access to the healthcare after COVID. So lot many patients started having health insurance, started going to the hospitals with no persistent cough, with slightest of the clinical signs. But this disease COVID-19 has somewhere hit the immunity of the body, in general, irrespective of the races. It has have some impact on the immunomodulation, and the way the all kind of malignancies which have been treated decades before, which were in remission, are coming back in some of the patients, not all patients. The general people who are listening to it, they need not be scared. But what we have observed, see, our understanding about the cancer has also evolved. We used to treat every tumor with chemotherapy, surgery, radiation. We tried to hit, and stronger the our impact, the tumor used to hit back again. Or this is called, this we used to call it, we still call it a recurrence from the remission. Now, after COVID, I have a couple of patients, as Dr. Sujit was mentioning, in lung cancer, there are targets, ALK, EGFR. And if you start oral targeted treatment, they go into remission. So I have a couple of patients who had COVID, and in couple of months, when the COVID scans were negative, subsequently they had malignancies, and which was florid malignancy. Now, I have never seen a ALK positive disease which never responded to a TKI. That has happened. There was a case of endometrial cancer treated 20 years back in remission. Had a couple of examples, but I have seen more than that. So somewhere I don't only on cancer, but the other diseases. You remember after the first and second or third wave, there was a mucormycosis. Suddenly the mucormycosis started, and Dr. Sujit and my colleagues will tell that mucormycosis was the maximum cases. The maximum number of cases we as an oncologist used to see in pediatric oncology, or leukemias or lymphoma cases, where we used to use high dose steroids. So all these opportunistic fungal infection or viral infection are used to be faced by oncology department, not no other department except the infectious disease. But after COVID, you remember this, there was a time when people have lost their eyes, the mucor has gone into the brain. So somewhere it has affected the immune system. I really don't know how long we are going to see the consequences of the COVID, but yes, we cancer is somewhere affected. New cases have come up in a bad way. Those patients who were in remission has come back. But yes, we are evolving in terms of diagnosis early, so we have to take things seriously. If something is persistent, any signs or symptom is persistent, so we need to evaluate, rule out malignancy in early stages, as we have no tools available to cure in early stages. Even though the patient goes into advanced stages, do proper staging, and do get adequate tissue to evaluate. As lung cancer, I see the way we treat lung cancer today is far better than what we used to do 10 years back. As I said, hardly we used to see patients surviving beyond 5 years. Now all of us are seeing at least 30-40% of the patients surviving beyond 5 years. Some of them are, again, I'll switch off the audio. So what is important, apart from our treatment, be it surgery, radiation, or chemotherapy, or immunotherapy, or targeted therapy, systemic therapy, we have to have a holistic approach or overall approach. The nutrition is also important, healthy lifestyle is also important, staying away from the addiction is also important. Not only our part of treatment is important, because everything helps the immunity to build up. So once we do our job, the tumor goes into remission. It is the patient's and patient family job to have a approach which is healthy, to build a good immunity which keeps the tumor into remission. And that is how the immunotherapy acts. It activates your immune system, and the immune system takes care of the tumor. It's not the chemotherapy drug which is hitting on the tumor and reducing the size of the tumor. So our understanding about the disease has evolved a lot. There are newer cellular therapies which are coming up in the form of CAR-T, which is largely successful in hematological malignancies, lymphoma, and blood cancers. There are a couple of trials going on for myeloma, which are successful. There are trials going on for solid tumors like prostate cancer. So future is very bright. To tell you, the genetic therapy, the gene therapy is evolving maybe 20, 30 years. Uh, Hopefully, we are sitting here and talking cure for all the cancers. But that is actually happening. Till that time, one has to understand the diet, the healthy lifestyle, staying away from the addiction, apart from treating any kind of cancer, is very, very important. Once we achieve a target of controlling the cancer, all these things are very, very important. And
Right.
again, the psychological aspects of the patients. Once you tell a patient you have a cancer, so it is very difficult for that person to come out of that trauma. So the counseling which happens has to involve the multidisciplinary, which goes beyond surgeon, radiation, medical oncology, the social worker, the psychosocial. No, there is something called as a psycho-oncology. No, there are oncology. In oncology, we have the psychologist. They do counsel, and that counseling is very, very important. And somewhere in some cities, it is important for the patient to bring to the hospital, because if you tell someone that you have a cancer, there is a myth associated with it that that's a dead end. It requires a lot of money, and unfortunately we lose those kind of patients who, like, say, no, EGFR or ALK positive patient, they don't come to the hospital. And these are the patients where we also try our best. Even if it is very costly, we try to arrange funds through, as I mentioned earlier, NGOs are there are lung connect groups, and there are groups. There is a group in Mumbai, lung connect, which connects different parts of the patients from different parts of the country, and some patients from the abroad. So where the information is given how the treatment can be accessed, even though it is very expensive. So all these things are very important. Though the treatment is very fancy, I understand that still in India, largely patients are not having access to the best treatment. But to some treatment which can change their lives, yes, we can help it out. But patient needs to come to the right person, as told by Dr. Sujit. There are different specialties, and the job has to be done of that specialty by that specialist. As no, chemotherapy should not be given by a surgeon, radiation should not be given by a medical oncologist, likewise. And but at the same time, the treatment should be planned by everybody sitting together, not necessarily everybody sitting in the same room. Thanks to the social media, where you can connect like this, sit and solve the problem. I think patient has the right to have the best treatment, which is decided in a multidisciplinary treatment groups, which is, we call it the MDT or JCs. So I think we are evolving. We have to understand post COVID changes. We have to understand the disease biology. Here it's a lung cancer, and we have to make sure that whatever latest advantage comes, in some or other way, we should try to bring it to the patient. And the last point I would like to say, the clinical trials. So now, largely in low and middle income countries like, say, African continent, Asian, our patients are deprived of clinical trials. And the problem is both ways. It's not that Western countries don't want to do clinical trials over here, but there is a resistance from inside also, from these countries. And there are some groups who will create cry about clinical trials. But those drugs, which once they are approved, and the cost of one cycle is beyond 10 lakh rupees, I'm talking about INR 10 lakh rupees, which are available to the patients through the clinical trials without any cost. That does not mean everybody should, but at least patient has a right to understand what kind of background that trial has. So every trial, when goes into phase 3, the drug is tested in phase 1, phase 2, the safety is actually tested, and then the drug comes into phase 3 trial. So such trials needs to be encouraged. These trials needs to be done in India, and that I think that is the only way to have access to these expensive medicines. So each
Right.
patient, each doctor needs to understand this.
Thank you, Dr. Bharat, for that wonderful answer. Dr. Animesh, if you can maybe unmute yourself and let's check your audio now.
Yeah, I think it should be fine now. I think the problem was with my earphones. I think I put that on mute accidentally.
All right,
Yeah.
no problem. So circling back to you, Dr. Bharat, lastly also mentioned about clinical trials. So my question to you was, what are some patient awareness initiatives and advocacy initiatives that, in your view, have changed the impact on lung cancer treatment? And for individuals who are interested to be part of such support groups or be, interested to be a part of such clinical trials, what are the steps that they can take? Please.
Let me just begin by first saying that patient advocacy in India really a thing. ठीक है. There is a government who is running the public healthcare system. The healthcare system is being stretched ridiculously thin by a huge caseload because India, let's face it, is still a very poor country. We are a low middle income country. The corporate sector is they are running a business and they have a P&L statement to look out for, and the patients unfortunately don't really figure in this anywhere. What exactly is patient advocacy is when somebody is actually standing up for the patient on the behalf of the patient when there is actually nothing in it for them. They're standing up for the patient. They are talking to the various agencies involved. They're talking to the government. They're talking to the healthcare sector and talking about what the patient actually requires. The government can only assess it from their end, but they cannot get the patient's perspective. So that is what a patient advocate group is supposed to do. And that really does not per se exist in that form in India. What does exist is various NGOs who are trying very hard to help out. So, like for pediatrics, I mean, for specifically for children's cancers, there will be organizations like, say, maybe let's off the top of my head, I know of a Can Kids who does very good work in Ahmedabad, where I did my DM from. So similarly, there are other organizations that are doing such kind of work. So these are the organizations who will liaison with patients and with us when we are working in the hospitals, and they will advocate for these patients, telling us what problems they are facing, how they can help them out. So these are the organizations that often create such kind of awareness programs such as these that we are right now having discussions about these questions and putting them out for the broader masses using social media today is an excellent tool. So putting these things out for everybody else to see. Geo has really democratized the internet. Everybody now has access to it. So everybody and the information is now freely available. So to point everybody in the right direction, to give to make that information more freely available to everybody, to try and reduce the trust barrier that now exists between healthcare providers and the general public. That is a very significant challenge right now. So, for instance, anybody who comes to me in my OPD, when I'm talking to them, one of the first things that I need to build with them is the trust. I need to be able to trust my patient. The patient needs to be able to trust me. It does not matter how confident I am in my abilities in treating him or her. So that kind of thing. So a patient advocacy group can bridge all of these divides, and that is the important role that they play. So it is right now a very fragmented ecosystem, mostly centered around the large centers that are treating oncology. For instance, Tata is a very prominent example. So Tata, in its various forms, where now they are really spreading their wings and setting up in various parts of the country, but previously confined to Mumbai. Institutes of excellence in Pondicherry, in Bangalore, in Trivandrum, in Ahmedabad, Delhi. So there are several such institutes that are trying to do this work, but it is a very fragmented system. How we can get involved is when we talk to these organizations, when we ask them how we can help, and this help is essentially in terms of being able to disseminate this information better. As in, not everybody is the right doctor for the same treatment, and everybody has to reach the right place for this particular treatment. As has been pointed out by the previous speakers, at the in cancer treatment is now a multidisciplinary approach. We cannot treat by ourselves. We recognize that. We need the help from our pathologists, from our radiologists, from anesthesiologists, and chaliye, let alone the clinical specialists, from psychological counselors, nutritionists. We need rehabilitation. Say a person has undergone treatment, but that cancer treatment takes a toll, not just the physically, mentally, emotionally, socially. Like we say, often say that cancer is not just treating the patient, we are treating the entire family. It can make or break entire lives, families. So all of this holistic approach, so all of this combined together will have to be taken care of by this patient advocacy. And patient advocacy can only come from for the time being, from people who are actually very interested and want to do it on their own. Because as of now, there is no real structure to this entire thing in our country. This is far more developed in the developed countries such as the US, where patient advocacy groups actually deal directly with, they lobby with the congressmen, with the, for example, in the US, they deal with this at the government level. They deal with the congressmen, they deal with the government, and they help and inform policy decision making. And that is the level at which patient advocacy functions. Because only that is the only level where actual change can be brought about. We need government support to be able to treat our patients better. PMJY is a very good step in that direction. For instance, a lot of the patients would come to our OPDs, let's say even 10 years ago, would end up having to go back because they just couldn't really afford the treatment. And we were very busy in our government setups. We are too busy to actually call up a patient and say ki aap dobara aaye kyun nahi. It is not really practical. So a lot of patients slip through the cracks, and there is nobody really to follow them up ki what happened to them thereafter. So this is the job that needs to be coordinated, and this actually is a very big lacuna right now in healthcare in India, and definitely in oncology.
Okay. Thank you, Dr. Animesh, for that answer. So with this, I'd like to bring this particular panel and the two rounds of discussion to an end. So a message that I would like each one of my panelists to give to everyone on this lung cancer awareness. We'll start with Dr. Sujit. So everyone who has joined us, a message from your side to all the viewers, to maybe your fellow healthcare professionals who are watching this particular panel. Please, Dr. Sujit.
So my advice would, I won't say advice. My 3 points would be: one, in preventive aspect. So first is stop smoking. Whoever is here listening, and tell your friends, because smoking is still the most common cause of lung cancer. Apart from that, more than 10 cancers can be attributed to smoking. And air pollution is second cause, but many times it's not possible for us to do. But at least smoking is one thing can be done. Stop smoking. Second thing is, if you have symptoms, if you have lung related symptoms, or if you have family members who have been smokers and have new symptoms which are not going, like breathlessness or having blood in sputum, please ask them to meet a pulmonologist. Get it properly evaluated. An X-ray may not be enough. A CT chest is not that costly. After COVID, we know CT chest is not that costly. A CT chest may be very useful if you are symptomatic. Get your evaluation done properly. And third thing, once you are diagnosed, I have seen, unfortunately, pulmonologists and doctors who are not in oncology telling patients who have stage 4 cancer that nothing can be done. You just unki seva karo, like that comment. So unfortunately, even among doctors, stage 4 cancer is still considered as uncurable. They don't understand the difference between targeted therapy or targets. I have seen myself patients who came late and they said कि आप pulmonologist told कि कुछ नहीं कर सकते. So that is not true. So if you have a lung cancer, or if you know someone who has lung cancer, please take an opinion from an oncologist, whoever is nearby, even if it's a surgical or medical or radiation. Meet an oncologist, they will tell you how to proceed. So once you have a diagnosis of cancer, do the proper evaluation, including molecular tests, including the chances. If immunotherapy is a different thing, but at least the targeted therapy which we are mentioning, they have medicines which are only available at 2000 rupees or less than that for a month. And even in government setup, they are available free. So if you have a lung cancer or someone you have, please get it evaluated, meet the oncologist, take an opinion. And the fourth, lung cancer diagnosis does not mean death. Patients are living and they are living long. Please don't get upset with such a diagnosis. Things have changed dramatically. So go ahead, meet a doctor, get it evaluated and get it treated. Definitely it can be cured. If not cured, it can be controlled, and they can have a good, peaceful, and asymptomatic, with no symptoms, a good quality of life. That's all. Thank you for the platform.
Thank you, Dr. Sujit, for that wonderful message. Dr. Bharat, your key takeaway for everyone who is watching this lung cancer awareness virtual discussion, please.
Yeah, so adding to what Dr. Sujit had said, is perfectly echo. No, I would like to echo the same thing. But now, now people do needs to understand this is something which is treatable. Certain extent, we can cure lung cancer now, even if in stage 3 and 4, which was not curable before. We have treatment modalities which can take the patients years ahead with the disease in control. One important thing is they have to go to the right doctor in right time. Be a little bit patient till the time all the tests are being done. See, there is something called as a window shopping kind of thing. I would like to use this word. No, see, once the word comes cancer, they want to have best possible treatment, but they have to believe all the doctors are good, but no, they need to speak it out. Speak all of your doubts. We are there, and till the time all the doubts are not answered, it is your right. So patient has to understand, believe in your doctor. Every doctor is for to do good things, not for harm. And I think the time is no more than 50-60% of the lung cancer we are seeing living beyond 5 years, and some of them are getting cured. So with this, and in coming years, that figure will go to 100%. So it's about just no keeping faith in your treating team. And one most important thing is not only smoking, all forms of tobacco are bad. In India, especially, it is the chewing tobacco which takes away no youngsters, the productive person from the family, away from the family. I think any form of tobacco is bad. Alcohol is again bad. Healthy lifestyle, do exercise, whatever form. That does not mean you should go and run for 100 kilometers. Even brisk walking is also important. Healthy diet is important as well. I was telling you, once you control the disease, the micro environment of the body can be built up by all these activities: good diet, good exercise. So, and that should start before any kind of a disease. Not only the cancer, but the hypertension and diabetes can also be controlled, because any kind of treatment adds again the morbidities in the form of metabolic syndrome. So stay healthy and keep yourself away from the disease. Even if lung cancer happens, it is treatable.
Right. Thank you, Dr. Bharat, for that wonderful message. Dr. Animesh, lastly, over to you. Your key take home message for all the viewers, please.
Uh, I I have to be very honest. Dr. Sujit and Bharat sir have already spoken very eloquently about what exactly we need to take away from here. So one thing that I would say, it's if it is not possible to stress on it more than enough, or we are overemphasizing tobacco in any form, please stop it. If you are taking it, there is nothing good will ever come of it. I mean, appearing cool, it is not cool. It is the most disgusting thing ever. Please stop it. And as for everything else, I can only say that yes, I would like to just echo everything that has been said. But yes, one more thing: just have a positive attitude, because the attitude of the patients, the attitude of the caregivers, of the family, everybody can also make a huge impact on the way the treatment is perceived, and in fact, in treatment responses, when it has been actually shown in research that the positive attitude can produce better results with the same treatment. So just try and stay positive, because as already they are proving, the world is actually getting better even for cancer patients, even for stage 4. So just stay positive. Try to do all the fact finding that you need to do. Don't window shop, as sir has rightly pointed out. Find the team that you trust and then stick with them, because at the end of the day, we all want what is best for you. We all want to get you better and keep you better for as long as we possibly can. So just stay positive, trust your team, and then let's hope for the best beyond that.
Thank you, Dr. Animesh. So with this, I'd like to bring this session to a closure. Firstly, I'd like to thank Pfizer for powering this particular virtual discussion. Nextly, I'd like to thank my esteemed panelists, Dr. Bharat, Dr. Abhishek, Dr. Sujit, and Dr. Animesh. Thank you for taking time out of your schedules to take this step and create awareness with worth of healthcare. And lastly, I'd like to thank all the viewers, everyone who has engaged with us in this educative session. Thank you, gentlemen. Have a good evening, and we appreciate it. Thank you.